Hi, and welcome to the 2023 Focus on Eye Health Summit. Thanks for joining us today for locations all across the U.S. and the world. I think we have 60 countries represented as well as 50 states. I'm Todd, President and CEO of Prevent Blindness. We're pleased to bring you these expert presentations, resources to support your vision work, and opportunities to connect with others throughout this interactive conference platform. For 115 years, Prevent Blindness has been dedicated to preventing blindness and preserving sight, a mission we elevate through three strategic pillars: educate, advocate, and empower. We know our work would not be possible without strategic partnerships, engaged stakeholders, and advocates for change. We thank all those who've worked with us to elevate vision and eye health as an important aspect of overall health, education, and employment. We're proud that Prevent Blindness can serve as a convening organization to bring folks together to explore these issues, how they impact millions of Americans and our friends around the world, and how we can help one another live our highest quality of lives. For over a decade, this summit has brought together diverse stakeholders to explore vision from a public health perspective. This year's summit carries the theme, Why the Eye?, serving as a reminder that the eye exists at the intersection of so many issues and should be a consideration for health policy, community interventions, and economic considerations. I'd like to thank the many sponsors without whom this event would not be possible. First, our platinum sponsors, the Alliance for Aging Research, Horizon, Pharma, and SIVA, the SIVA Foundation. And then our gold sponsors, Apellis, Bio, and the Bright Focus Foundation, the Center for Vision and Population Health, the National Center for Children's Vision and Eye Health, and Regeneron, and all our many silver sponsors. I encourage you to visit all of them in our exhibit hall later today. We couldn't do this work without them. We encourage you to take full advantage of this virtual event by attending the presentations in the auditorium, browsing our on-demand video library, visiting sponsor booths in the exhibit hall, and engaging with other attendees throughout our chat feature. You'll find that many of our speakers today will be available for 30-minute video chats after the presentations to answer further questions. You can access these chats by going to the auditorium and clicking on the link in the session descriptions. This link will also be provided during each speaker's presentation in the chat section. And for those of you with a competitive spirit, we have prizes available for those who engage most with this platform throughout the event. You can visit the leadership board for more details. A link to all presentations will be available on the Prevent Blindness website at preventblindness.org, where you can also access presentations from previous summits. Links to the Prevent Blindness social media accounts are available in the lounge. Please share this event on social media, and you can follow everything that is presented at the summit today on Twitter at #iSummit. Today, we will have Q&A at the end of the sessions. You can submit your question through the chat button at the bottom of your screen, and we'll respond to as many as time allows. And before we get into the summit, I'd like to pitch a campaign that Prevent Blindness currently has underway. In the coming 6 to 9 months, we'll have 2 major eclipses here in the US, one in October of this year and one in April of next year. Most of you know that it's important to wear your eye protection if you're watching the eclipse, an incredible event. And we have a lot more information on our website about how to protect your eyes. You can also go to our website to purchase your safety eyewear. Visit our exhibit booth today to learn more about this campaign, or visit us on our website. And now I invite you to sit back and enjoy today's presentations. First, I'd like to introduce our keynote presenter to kick off the summit. Dr. Neil Bressler is the editor-in-chief at JAMA Ophthalmology and professor of ophthalmology at Johns Hopkins School of Medicine. He'll discuss how recent innovations are advancing eye care and how they're impacting the patient. If you have questions throughout, please submit those and we'll answer as many as we can after the session. And now please welcome Dr. Bressler.
Jeff, thank you so much for the opportunity to join you and all the people at Prevent Blindness, and for the opportunity really to talk about what advances in eye care have gone on and the impact these may have on the patient, because this is your mission, and I'm happy to report the mission is going well. We just have a lot more to do. I'm going to show you first my financial disclosures. These involve numerous companies that provide grants to the Johns Hopkins University for us to do some of the research that I'll be presenting today. And before we get to the advances in eye care, I want to start just with the overall why the eye. This is a well-characterized survey that was published in JAMA Ophthalmology almost 10 years ago, looking at perceptions of people in the United States and their public attitudes about eye and vision health. The New York Times picked up on this and said, you know, the worst thing that could happen, looking at this article, it appears that going blind is maybe one of the worst things that we perceive could happen to us. This was back in 2017. And at that point, when this survey of people throughout the United States were asked, on a scale of 1 to 10, with 1 having the least impact and 10 having the greatest impact on your daily life, how would you rate losing your eyesight? And what you can see here in blue, which is a 10, is that across all races and ethnicities, one of the most common answers was a 10, that losing your eyesight was one of the worst things that could happen. Another way of looking at that is to look at all the choices that people were given. And there were more than this, but looking at blindness or cancer or symptomatic AIDS or having Alzheimer's or not being sure, again, blindness across all races and ethnicities, across all these possible terrible things that could happen to our quality of life, is one of the major reasons that people are interested in trying to reduce the magnitude of vision loss and blindness, not only in the United States, but throughout the world. In fact, we can often look at utility values across all other health problems. And if we look at what moderate visual loss is like, this is when somebody reads on the chart and needs the letters to be 4 or 5 times larger than just the 20/20 line, that has a utility value of about 0.72. What does 0.72 mean? Well, actually, if you have a moderate stroke or if you've been on home dialysis for almost a decade, that also has a utility value of about 0.72. It just shows you the magnitude that vision loss can have on all of us. It's even lower, as you see in the bottom left here, if you have 2200 or worse vision. And so what happens, the reason is because we're just not able to do a lot of our daily tasks, trying to recognize landmarks or street signs, trying to look up close and read perhaps a prescription bottle, or writing a check, or just cooking or shopping, trying to take care of ourselves. Perhaps we have to look at our insulin injections or our glucose testing, or just our social participation. By not being able to see who walked into the room, you know someone walked into the room, but you can't see the details of the face to know, is that a stranger? Is that my best friend who will be insulted if I don't recognize them? And so vision loss has a profound effect on how we interact in our work, in our play, in our socialization each and every day. Now, I'm going to talk about 2 of the 3 leading causes of blindness, not only in the United States, but in much of the rest of the world: diabetic retinopathy, age-related macular degeneration, and glaucoma. That's not to take away from all the other eye diseases that are just as important, whether they affect hundreds of thousands or millions of people each year, or even if they are very rare diseases and only affect 50 people, they affect vision. But I'm very comfortable as a retina specialist sharing with you some of the research that has been done and some of the impact this has had on how we take care of patients, not only, as I said, in the United States, but throughout the world. Now, we have a lot of different people on this webinar. And so I'm just going to start with the basics. If you think about the eye and you think about where cataract forms, that forms in the lens, right in the middle part of the eye, below the pupil there. Behind the lens is the vitreous. This is a cavity of gel that fills the eye. It's not filled with air. It's filled typically with this vitreous gel, and that goes up against the inside back wall lining of the eye. That's the retina. The retina is supported by a blood vessel supply, which is the choroid, and then around all of that is a structural support, the white sclera that we look at. Now, I'm going to concentrate on two of these three major causes of blindness that happen to affect the retina: diabetic retinopathy and macular degeneration. Let's start with diabetic retinopathy. Why does this happen? When people have high blood sugar levels, when their hemoglobin A1C is abnormal because either in association with obesity or because their pancreas is not working properly, they have high levels of blood glucose. This can affect the retina capillaries that line the inner surface of the retina. What happens is these very tiny capillaries have structural support by cells which are called pericytes, but high blood sugar levels damage these pericytes so that they no longer can support the capillaries, and the capillaries can either close off or become leaky. In addition, the very capillary cells themselves, not the pericytes supporting them, but the very capillary cells themselves can have their supporting structure called the basement membrane begin to thicken when somebody has high blood sugar levels for a certain period of time. And this loss of pericytes, this thickening of the capillary cell basement membranes can cause the blood vessels to leak. They ooze out fluid, much like if you had a burn on the surface of your skin and a little fluid would come out. These blood vessels are not supposed to ooze out fluid, but they can, and this can cause the center part of the retina, the macula, which is the part we use to see these slides, to recognize somebody's face, to read, to drive, to see a screen or the television. This causes the macula to swell like a dry sponge filling with water. It becomes edematous. And this is one of the two ways, this is the very common way, that people can lose vision from diabetes. It damages these capillaries. The capillaries then leak fluid. The fluid causes the retina to swell, what we call diabetic macular edema. Now, you can't see it too well looking in the retina. This is just a black and white photograph of the back of the eye. You can see little dots, which are little hemorrhage there. There's a vertical line, a black vertical line at the top of this slide. That's just a pointer. It's a shadow of a pointer that a person was using to look right at this center of that line. But the abnormal damage to the vessels causes blood to leak out, and then it can thicken. You can see this leakage when we inject fluorescein into the vein of someone who has diabetic retinopathy sometimes. So this fluorescein, it's not an X-ray, it's a black and white picture, but this fluorescein can be detected with different filters on the camera. And this is it about 30 seconds, about half a minute after that fluorescein was injected into the vein of the person. And then 10 minutes later, it's leaking. And this is just showing us where there's fluid leaking into the retina. But we can actually see this in this patient who, again, has visual acuity of 20/63. They need letters that are about 6 times or 3 times larger than the normal size of a letter, that's 20/20. And you can do a cross-section called optical coherence tomography and see how these dark spaces in the middle are swelling. It's where this fluid from these capillaries have caused this swelling or this diabetic macular edema. And you can measure this down to almost 1,000th of a micron. We can see that this retina is 462 microns. It should be about 250 microns, but it's thickened from this fluid. Now, this is a huge problem. In 2014, around the world, there were about 400 million people who were living with diabetes, and we need to identify who are the 100 million that might have diabetic retinopathy, or the 21 million who have this thickening, this diabetic macular edema. This is a big challenge because we can't necessarily look in the back of everybody's eye. we don't have enough personnel, and we have to reach out to these people. Maybe they're in a city where they have access to good care, but maybe they're not. And of those 21 million people that might have edema, we have to monitor them if we're going to begin to treat them and see if our treatments are working. And perhaps as the treatment effect wears off, begin to treat them again. So these are huge public health problems. Just a few weeks ago in JAMA Ophthalmology, this group from the Centers for Disease Control in Atlanta published an update on what this prevalence of diabetic retinopathy was in the United States. And this can pretty much reflect the world as well. So even under the best healthcare that people were trying to do in the US, it was shown that the prevalence of diabetic retinopathy was going up tremendously, almost double. And here we can see that about 10 million people in the US had some diabetic retinopathy. And among all the people with diabetes, about 25% had some diabetic retinopathy, just showing the magnitude of this public health problem. This is why we're encouraging people to do research in diabetic retinopathy to try to reduce the magnitude of vision loss from this problem. This shows you across the various age groups. And if you look at the black line, which is the total, if we look at the groups between 65 and 70, about 25% of all people with diabetes have diabetic retinopathy. But there's some disparities here that you can see. If we look at non-Hispanic Blacks, it's 35% between the ages of 65 and 70. And this likely is associated with access to care and the care that's being received. And it just points out, not only is it a big public health problem, it's a public health problem that can vary across numerous groups that we need to be able to improve in everyone. This shows you the people who have vision-threatening diabetic retinopathy, changes that cause this swelling, or another area of diabetic retinopathy that I'm not going to have time to discuss today, called proliferative diabetic retinopathy. And what this shows us is that about almost 6% of people with diabetes have vision-threatening diabetic retinopathy. They need some sort of monitoring and treatment promptly. And again, you can see that there are disparities to this, where in non-Hispanic Blacks, 10% between the ages of 65 and 70 have some vision-threatening diabetic retinopathy, the most dangerous form of diabetic retinopathy that is threatening permanent vision loss. Well, fortunately, we've begun to get treatments that can address this problem, even though it's a growing problem in the United States and the world. So in 1986, it was first learned that you could use focal discrete spots of laser to some of these areas of leakage, and it could reduce the chance over 3 years of having at least a moderate amount of vision loss from 30% if you did nothing to about 15%. This was very important. You could cut in half the number of people that were having at least a moderate amount of vision loss, but still 15%. That's still 1 out of 6 people. And it actually took 25 years until we had a new treatment that could improve on this. The purple line below is using standard laser, showing that at a year, shown on the dotted line, you could get some gain in vision on average. But it wasn't as good as what you could get by periodically injecting as needed an anti-VEGF, in this case, ranibizumab. This was done by the Diabetic Retinopathy Clinical Research Network and published even before the companies who make these anti-VEGF agents were able to complete and submit their trials to the FDA for approval. So before this agent was even approved for diabetic macular edema, it had already been approved for the neovascular or wet form of macular degeneration. And the network, sponsored by the National Eye Institute of the National Institutes of Health, quickly organized a study that showed you could use this anti-VEGF and actually get better outcomes than with laser. And this was then confirmed by numerous industries, many of whom are supporting this work today, by numerous industries that were able to get this approved by the FDA and by other regulatory authorities around the world, so that we could give better treatment than what we had with laser. And then the DRCR network published in 2015, looking at the various agents that came out for this, aflibercept, or repackaged or compounded bevacizumab, which is an off-label use of that drug, which was first developed for metastatic colon cancer, or ranibizumab. The aflibercept and ranibizumab were designed to be injected into the middle cavity of the eye to try to get rid of this edema. And it showed, for example, if we use aflibercept and you found the person when they were 20/50 or worse, 45% of them by 2 years were 20/25 or better. But in fact, if you could identify people who had diabetic macular edema when their vision was 20/32 to 20/40, if you could catch them earlier, 70% 2 years later would be 20/25 or better. And then in just a couple of years in 2019, the DRCR network published this protocol, Protocol V, looking at what if you catch people before they even have symptoms from their diabetic macular edema when it's just beginning to thicken, but their vision might be 20/25 or even 20/20. And they showed you could start with the aflibercept on the left there, but you could also just observe them and rescue them with aflibercept if their vision began to drop. And then 85%, no matter which regimen you use, 2 years later ended up 20/25 or better. So we now know how to manage these people. We need to identify who has edema. And we want to catch it even before they have any vision loss, meaning everyone with diabetes needs to have at least once a year the back part of their eye monitored to say, am I beginning to develop edema or not? Even if they can read, even if they can drive, even if they can see 20/20 on an eye chart, because they may have the beginning of edema. And then we can observe them as shown on the right-hand slide here, but rescue them with an anti-VEGF agent if their vision begins to drop, and then they can be 20/25 or better. Not only 45% 20/25 or better if they come in when their vision's already 20/50 or worse, not 73% ending up 20/25 or better if you caught them just as their vision was beginning to drop, but 85% at 20/25 or better. Now, in these bottom two examples, we need to periodically give repeat injections into the middle cavity of the eye because the agents can wear off over time. And in some people, they don't need more, but in other people, they need more of this agent. And in median of 14 injections, 9 in the first year, 5 in the second, were needed when the visual acuity was 20/32 or worse. But if we could catch these people early at 20/25 or better, and then they need to be treated, a median of only 8 injections is needed over 2 years, so that not only do we preserve more vision, but we need less resources to try to treat. Now let's switch to macular degeneration, another major cause of blindness. In this case, debris collects in the basement membrane, in the supporting structure of one layer of cells that are shown in yellow here with those little red circles in them, the retinal pigment epithelium. And below that, the white arrows on the cartoon sketch are pointing to this drusen material. You can see this drusen by the black arrows looking in the retina. It's some debris that collects in the retina. But again, the person is 20/20 when this first develops and may not notice this at all. So the drusen early on by themselves do not cause vision loss, but we need to look in the back of everybody's eye that's over the age of 50 to say who's developing this debris or not, so we could follow them and treat them for complications that might develop from this debris. One complication is the debris can cause disintegration of the RPE, or the retinal pigment epithelial cells, and the photoreceptors that overlie that, what we call geographic atrophy, because on the right, those arrows are pointing to lighter areas where the photoreceptors, the rods and cones, are being lost as they were overlying drusen for over a decade. They might just disintegrate away. Now, recently, several companies have identified agents that might be able to slow down this growth of the atrophy. Now, they don't slow down any vision loss, so we still have a long way to go in trying to treat it, but at least it's a step in the right direction, showing us that maybe there's hope for even slowing down the growth of this atrophy if we can catch it early enough. But what often happens when people have this drusen material maybe 25% of the people who get this. It stimulates growth factors to cause blood vessels to grow from the choroid, from the supporting structure of the rods and cones, with scar tissue into the retina. And this can permanently scar the retina. Now, if you catch this early on, you can use and inject these anti-growth factors, the very same factors that are involved in causing swelling of the retina in diabetic macular edema are these same factors that in macular degeneration can cause this growth of abnormal blood vessels and scar tissue. And if you catch it early on, you might prevent it. Well, just a few years ago, the same group of people from the CDC and others looked at what's the prevalence of macular degeneration. And this is looking just in 2019. Again, a huge public health problem. Of all the people 40 and older, there were 18 million that had age-related macular degeneration. And this was a big problem because it was about almost 12% of everybody over the age of 40. And if we look at the late stage, among all these people over the age of 40, 1.5 million people in the United States had this late stage of these blood vessels and scar tissue or very extensive atrophy developing in the back of the eye. And this was about 1 million of all the people who we saw over the age of 40 that, or about 90.94 million that had this change. Now, again, if we look by various ages, this is really increasing. There's an inflection point as we get over the age of 65. And at 75, we can see that over 20% of the people, of everybody, will have some amount of this debris of macular degeneration. Now, it is a little less common in non-Hispanic Blacks, unlike with diabetic retinopathy, but it's still 15%, still 1 out of 6 of everybody over the age of 75. So we have to recognize this is a risk for everyone, even though the risk may be slightly less for some individuals than others. And there's an inflection point of getting this advanced stage after the age of 75. After the age of 75, many people who have this drusen are getting this wet form, this growth factors of blood vessels and scar tissue from macular degeneration, or the dry form. You can see by the time you get to somebody in their 90s, 1 out of 6 of everybody in their 90s has this advanced stage where they've lost substantial vision or are at risk of losing substantial vision. Again, a little less in non-Hispanic Blacks, but still 10% of everybody over the age of 90. So there probably are, by 2050, going to be about 1.6 billion people over the age of 65 when this inflection point of this drusen develops. And we need to identify the 15%, or about 240 million of them, who have these drusen without any symptoms, so we can follow them and treat them. And we want to perhaps find them when they're just developing just the drusen material, because the age-related eye disease study sponsored by the National Eye Institute showed if you gave somebody with this debris or this drusen a dietary supplement that was antioxidants plus zinc, their risk of getting this advanced stage was not 28% for the ones that got placebo by 5 years, but 20%. And that can translate, as was estimated in 2003, to a lot of people avoiding the advanced stage. There were about 59 million people in 2003 who were over the age of 55. By now, it's double that. It's 120 million in the United States. And in 2003, about 5 million had the intermediate stage, this debris in one eye. Another 2.2 million had the intermediate stage in both eyes, and about 1 million had the advanced stage. So about 8 million were at risk of getting the advanced stage in one or both eyes. And you can double that. It's about 16 million are at risk right now in the United States. And if you were able to reduce that risk of the advanced stage from 28% to 20% with those dietary supplements, you could reduce, instead of 1.3 million people in 5 years developing this advanced stage, you could make it about 320,000. And now, if we can get these people to take this dietary supplement, this age-related eye disease study suggests that maybe that formulation that was given in that trial, not any vitamin that you can buy over the counter, but that specific formulation might reduce over 5 years having 650,000 people just in the US alone from getting the advanced stage. But what if they do get the advanced stage? Because it doesn't stop everyone. We learned in 2005 that you could use this anti-VEGF, in this case it was ranibizumab, and instead of having about 65% of the people avoid substantial vision loss, that went up to 90% that could avoid substantial vision loss. And about 30 to 40% could actually get vision gain when they're giving this. And it's less than 5% that get vision gain when they walk in with this neovascular or wet form. And so we want to be able to give anti-VEGF to have at least 30 to 40% gain vision, but about 90% avoiding losing vision. And that means we have to detect them early on. You can see here that if you look at what the baseline vision is when somebody walks in this trial sponsored by the National Eye Institute, which was the CAT trial looking at repackaged bevacizumab or using ranibizumab to treat this wet or neovascular form of macular degeneration. If you look at where their vision is at 12 months, if you start around 2032 on the red line, you end up still almost about 2032. We have to catch these people just as the neovascular process is forming, not when they start at 2200 and maybe only can improve to about 2160. So we need to come up with ways of monitoring these people at home and detect just as their vision is being lost. But we need to know who has the intermediate stage, who needs this monitoring in the first place. Those people then could consider dietary supplements. They could be evaluated for asymptomatic changes periodically with that OCT examination. They could continue home monitoring so that just as they develop it, it might get them in while their visual acuity is quite good. And there are many studies looking at this. And then once we have to manage them, if we see that it's progressing, we want to initiate these anti-VEGF therapies to preserve their vision, but we want to do it as soon as they begin to lose vision and monitor them frequently. So these are big public health problems. Again, 1.6 billion people. We have to find the 240 million who have this intermediate stage. And in the US alone, 150,000 who are developing the advanced neovascular form. They need to be monitored to be able to tell us when they need to be treated, when we can withhold treatment. Home monitoring may be a solution in the future. Having phones are around everywhere in the world, and maybe people can begin to come up with ways of periodically monitoring their vision in a reliable way that will tell them you need to come in and maybe be evaluated to see if you need treatment. There are various visual acuity testing going on. There's various shape discrimination tests that go on, and even studies that are looking at just a few weeks ago using an image from a smartphone that might be able to tell us what's the person's visual acuity and is it dropping? Because we can look at this patient and we know they have diabetic macular edema, or we know this patient has macular degeneration, but we don't know what their visual acuity would be on a chart. But one of the good things of artificial intelligence is that you might be able to use that to evaluate these photographs and tell us what is this person's best corrected visual acuity if all I show you is an image of their retina from their phone, or even if they walked into clinic and I got an image of their retina. Do I have to measure their visual acuity and refract them to look on the chart? Might we be able to use AI to allow us to monitor these people around the world and tell us when they need to come in for this treatment? This is something that our group did with the Applied Physics Lab and just published a few weeks ago that we're getting there. We were able, within 8 letters on a chart of 0 to 100 letters, be able to identify what the best corrected visual acuity would be if you refracted that person and measure them on a chart, just by having artificial intelligence evaluate the retina photograph that they had. And again, that's not quite good enough. We want to get it to within 5 letters, but it's a start. And all of this research may help us in managing this huge public health problem. So this needs to be looked at in the clinical practice setting. It needs to be looked at in macular degeneration so that maybe around the world we can get access to people who can monitor their visual acuity just from an image, and we could perhaps be able to tell who needs these treatments. So that was just a world force tour on why the eye, just looking at two of the many common causes of vision loss and the impact that it's having on the patient. We should remember why the eye, because blindness is perceived as one of the worst things that can happen to us. But there's good news. The major causes of blindness in the US and much of the world in diabetic retinopathy, age-related macular degeneration, open-angle glaucoma, and many others that I didn't have a chance to mention are having more and more treatments that are able to affect our clinical practice and improve the vision of these people or prevent vision loss in these millions of people who are at risk of losing vision each and every day. But access to eye care across all socioeconomic groups is going to be critical because early detection or prevention is going to lead to better vision outcomes. And maybe home monitoring over this next decade will allow us to determine visual acuities or allow us to look into a fundus and determine, does this person need to start treatment? Do they need to come back for additional treatment? And while there's a lot of controversy on where we're going with artificial intelligence for the eye and for imaging the retina, this may really help us address some of the magnitude of the problem. And we will continue to look for ways of diagnosing, managing, and preventing vision loss. And I'll tell you, it looks very bright because of the work that Prevent Blindness does. And Jeff, I have to thank you personally as their leader and CEO. I know it takes a village to do all this and put it together, but having you support these efforts and allowing us to get access to research funds and then share the results and then have ophthalmologists, optometrists, other eye care providers around the world work on this has made such a difference for all of us. And I'm hopeful that having these opportunities of sharing this information will allow us to perhaps in the future be able to talk about not only are there millions of people that are at risk for this, but almost all of them were able to prevent blindness. And thank you for letting me share that.
Thank you so much, Dr. Bressler. That was really terrific. And we got quite a few questions, unsurprisingly. So let's just jump into these and see how many we can answer and in the time we have left.
Happy to.
Given the large prevalence of diabetes and diabetic retinopathy, along with the lack of eye care or of eye health care professionals, what are some effective screening methods that other fields in medicine or public health could use to help screen for diabetic retinopathy in diabetic patients?
It's quite a challenge because very often there are so many doctors for somebody with diabetes that they have to see. They might have someone managing their blood glucose. They might need to go to a podiatrist for problems with their toes. They may need to go to a kidney specialist because they're having kidney problems. And the findings in the eye are so distinct that you need special equipment to see it. And so we're constantly working with our internists and saying, I know we're all physicians, or I know we're all healthcare providers, but this is unique. And you need to get the person in to see an eye care provider who can image the back of the eye and say, do you need to just be seen in another year, 2 or 3? Or do I need to see you next year? It's just not possible for someone who is not trained in getting these images and having the equipment to evaluate them to be able to accurately identify the earliest stages. Yes, when it gets very advanced, they might be able to tell, but by then the person has vision loss. And so we're really trying to change the paradigm and say, it's not something we can put into the hands of the internist, of the podiatrist. It's something that needs to be referred right now. But the hope is that you can get it on a phone, that almost everybody, not everybody, would have a phone to be able to image and say, you need to go to this specialist because there's a change in your retina for diabetic retinopathy. So we've tried to do it in consort with non-eye healthcare providers. And because of the specialty of the equipment and the changes that happen early on, we've really encouraged people to say, just get them to someone who can do that. It's not something you can do to easily screen. And everyone who has diabetes needs it. They may only need it every 2 years, but they may need it every 2 months, and you can't determine until you image it.
Yeah, so really we need to work to get everyone with diabetes into eye care and have conversations with their doctor about how frequently to be checked and followed up there.
In almost all cases, yeah.
Thank you. Real quick, you mentioned AI and fundus images. What are some issues with deploying AI models and fundus images, and how large of a training data set is necessary for accurate results? Any thoughts on that?
Yeah, the like our human brains, the more you train on, the more likely you're going to be accurate with your diagnoses or your surgery. And in this case, we know that you can do an okay job with just several hundred images. And very bright computer engineers are able to manipulate those images in ways that they can help enhance the training of a machine. But typically you need thousands of images, number one. And so that's okay. We have to figure out ways of doing that. And number two, the computer can only do as good as what it trains on. So if you only show it individuals between the ages of 40 and 60 to train on, maybe the retina looks different in people who are 75 and older, and it may make errors in what it's trying to do in that way. And you have to be very careful of biasing the teaching in that way. But nevertheless, hundreds are needed to start getting exploratory answers. Thousands are probably needed to get definitive answers that we might be able to depend on as healthcare providers. And I hope it'll keep improving from there.
Well, and somewhat related to that, I see a question here from Dr. Mitch Brinks, a member of our board of directors, who asks, what is the role for OCT versus fundus photos in screening for diabetic retinopathy or AMD?
Yeah, so that's also a great question. So the OCT is fantastic because it gives us a almost microscopic cross-sectional view of the retina where these problems occur. The challenge is the equipment can cost tens of thousands of dollars in the clinic, and not everybody can easily get to a clinic or get to it every month to have it evaluated in that way if it's needed in that way. And there are some OCT devices that are being made for the home, and that might be an answer for some individuals, but it doesn't tell you the visual acuity. And so there can be people who are thickened but have 20/20 vision, and they may not need any treatment. We need to know when they're thickened and their vision is dropping. So you really need the visual acuity. We don't have a way of getting the visual acuity from the OCT so far. We might, but the reason some of us were pursuing getting it from a fundus image is because you can't put an OCT yet in a phone camera, but you sure can get an image from a phone camera. And so just for practicality of what's ubiquitous in the world, looking at a fundus image would be helpful. In practical screening, if you were the CDC and you wanted to see who has what, if costs were no issue, you'd get both a fundus photograph and an OCT. But for screening these hundreds of millions of people with diabetes who may have changes, we might have to reserve the OCT for our care in the clinic and try to get fundus images from visible light that can already be obtained from phone cameras. It's not perfected in any way yet, but might be able to be using that in the future.
Thanks. And based on that comment, I have to give a plug. One of the things we do here at Prevent Blindness is advocate for increased funding at the CDC, which you just mentioned, and their work around surveillance. And one of the challenges is they just don't have enough money to do the proper surveillance, purchase the proper equipment, and really help us understand the scope of the problem. So anyone watching, please go to our advocacy website and sign up for alerts and get engaged in our work to try to increase funding there. So here's an interesting question. Is there a limit to how much laser you can have in your lifetime? How much can an eye handle?
There is and there isn't. So you typically don't want to re-laser over an area that's already been lasered, because where you apply the laser, often the retina has been destroyed. And so you're just putting destruction on something that's already destroyed, and it might cause some iatrogenic problems. And that's why it's great that if you've used laser to try to treat diabetic retinopathy or even macular degeneration, and there's still additional problems going on that are driven by vascular endothelial growth factors, you're able to use anti-vascular endothelial growth factors to treat them. So it is true that the more laser you use, the more areas of damage to the retina you will do, and that will cause more damage to the vision. Sometimes that damage outweighs the damage of not using the laser. So that's a judgment that has to be made by the ophthalmologist who is considering the laser in an individual. But there's not too much of a limit. If somebody judges that you need laser, they're saying that's because if I don't give you a laser, you're going to do even worse. The same, fortunately, is true with anti-VEGF. There's no limit to the number of injections that you could get in a lifetime. We've not seen any long-term consequences of having 50, 100, 300, 500 injections as frequently as monthly if needed. Now, we hope that we can come up with ways where you only have to inject something once a year, perhaps. But even if there's a circumstance where an individual eye needs it almost monthly, fortunately, there's no limit to that right now.
Thank you for that. Here's an interesting one. Obviously we'd love to prevent vision loss from diabetes and AMD, but that's not always necessarily possible. So what are your thoughts about the role of low vision rehabilitation in the process, and how do we integrate that with the care of trying to stop or slow vision loss?
It's extremely critical, and even the term low vision may not be the best one, and maybe impaired vision or lack of 20/20 vision. And time just did not permit to emphasize how important it is to work with rehabilitation people, because you typically don't get all the vision back. There might be some initial damage, and maybe you're fortunate you can halt it right there. But you might need a low vision rehabilitation specialist to help you deal with what was left. Maybe there's a lot left and you need just a little brighter monitor or a little larger font on what you're using. But maybe there's been a lot of central damage and you need very sophisticated electronic or other equipment to be able to use what you still have. So it is very important to support work in the low vision rehabilitation area, and to ideally get funding to support purchasing that rehabilitation equipment when warranted, because you need to use that to maximize your ability to do all those things we said are critical, to either watch the television or see your phone or be able to cook or read the label on a prescription. And that's why, as I said, I can't emphasize enough that we need this impaired vision. If it's not 20/20 with glasses, it's impaired. And we shouldn't think of it as low vision per se. Maybe it's 20/25 in some cases. Maybe it is 2200 and quite low in other cases.
Thank you so much for that. And gosh, I wish we had another hour. We have so many more questions, but unfortunately we are at the end of this session. Thank you again, Dr. Bressler, for your time today.